All right, welcome back, everybody. We hope you enjoyed your break and got a little refresher. An hour goes by pretty fast in these things. So I want to just go back and recap kind of the ground rules of this afternoon. Remember, only patients and caregivers are the ones that are allowed to speak during the meeting. We appreciate everybody being here, but we're going to keep it to the patients and the caregivers. We're going to have a respect for each other's emotions as we go through this. As we saw this morning, it can be quite emotional. And the last rule, of course, is I get to ask all the questions. And to set up this afternoon, we're going to kind of do the same thing. We're going to be able to have a doctor come up and speak a little bit to talk about current and future treatments. Then we're going to go into our panelists, or we'll do some polling. Then we'll go into, we'll go into our panelists. Then we will do some polling, and we'll go into an open discussion again. So we're very excited and honored to actually bring up Dr. Michael Mannstadt. He has been so pivotal in helping the hypopara community. So Dr. Mannstadt.
Patty and Michelle, thank you so much for inviting me here. Thanks, everyone. This has been a very moving and deeply humbling morning, and I'm very grateful to be here. So I was asked to speak about current treatments. I didn't hear the future treatments, but that's okay. So I am an endocrinologist in Boston. These are my disclosures. And so in the middle of, or the center of the discussion is really PTH, parathyroid hormone. And when we talk about treatments, we need to know what PTH does, because that's the one that's missing, and we want to replace its functions. And so you see in the middle in red the PTH, parathyroid hormone, which increases, and you see on the bottom, calcium in the blood. That's well known to everyone. But I want to pause here and really emphasize what the parathyroid glands are doing. Namely, there is this nice negative feedback that we like so much in endocrinology, that in calcium that is elevated will put a brake on the parathyroids through the calcium sensing receptor, and then less PTH is produced, and therefore less calcium in the blood. Calcium goes down, and if it is a little too low, then the brake actually gets released, and there's more PTH produced, and that leads to the calcium level to be regulated really in a very narrow range. And this happens while we have lunch, or if you sit in a conference and don't eat anything, or we're going out and exercise. Unbeknownst to us, it has a minute-to-minute regulation. And now compare that to what we are currently doing with our treatments, right? Which is almost a sledgehammer approach. And then let's dissect a little more what PTH is doing. And so number one, it increases bone turnover and the release of calcium and phosphate into the blood. It tells the kidneys to reclaim the calcium so that there's less calcium in the urine, but really there's then more in the blood. It leads to an excretion, to getting rid of the phosphate that is so abundant in our diets. And through the increase in the production in the kidneys of calcitriol, the active vitamin D, it increases indirectly the absorption of calcium. And no PTH, of course, we have hypoparathyroidism with low calcium, high phosphate, and low bone turnover. And the conventional treatment with calcium and vitamin D, all it does is, it's number 4. It increases the absorption of calcium. That's all that it's doing. Nothing number 1, 2, or 3. And I'm glad people talked about the number of tablets. This is just an example of a very average hypopara patient taking 2 calcium citrate tablets 3 times a day, and calcitriol 0.25 twice a day. That's a very, medium level of medication. These are already 8 tablets. And 8 tablets and plus, all the rest that might be needed every day. That's kind of not an easy way to treat a disease. The other medication that is FDA approved is PTH 1-84 or Netpara, once daily subcutaneous injection. And as we know, unfortunately, the production will cease by the end of this year. So what are the consequences of the calcium and calcitriol therapy, these long-term complications? I just mentioned a few of them, and we have already discussed some of them. Renal complications, cataracts, brain calcifications, depression, cardiovascular disease, infections, and skeletal complications. So it's really not a benign disease. And what I like to do is just take an example of all of these complications and talk a little more about this, and these are the renal complications. So on the left, you see what is normally happening if you have normal parathyroid glands with PTH producing. And you see that in the lower part of the left panel, the serum calcium is increased by reabsorption, reclaiming the calcium from the urine. And on the right side, you see this is not working if there's no PTH and there's loss of calcium in the urine. And all that we are doing with giving oral calcium and calcitriol, we are increasing serum calcium, but at the same time increasing urinary calcium excretion, right? There's a strong correlation between the two. And so the loss of calcium in the urine is not something you can feel, but there might be long-term consequences. And so there was this study done in Boston, more than 10 years ago, where we examined the charts of 120 patients with chronic hypoparathyroidism. And on the left side, we identified about half of the cohort having some imaging done. And when we looked, or a radiologist looked at the images, almost a third of those who had imaging done had kidney stones or nephrocalcinosis. And you see these two red arrows. They point to these white spots. These are kidney stones of one of the patients in the trial. Around these kidney stones, that's the normal kidney, and in the middle, this white thing is it's the spine. And so does that impair or have anything to do with kidney function? On the right side, you see a diagram that shows you the proportion of patients with chronic kidney disease, CKD. And the black bars is the normal, or taken from the normal US population. You see a well-known age-dependent increase in chronic kidney disease. You see the different brackets of ages. And then when you superimpose our patients with hypoparathyroidism in the gray bars, you see that there is a several-fold increase in the prevalence of chronic kidney disease in patients with hypoparathyroidism. So really that told us, Houston, we've had a problem. And this study was followed by many other studies. This is from a review that shows you the percent of patients with chronic kidney disease. And on the left, you see the N numbers. These are the numbers of patients within each of these studies. You see it ranges from 33 to really large studies. The last one is from the nationwide Danish study with 688 patients. And from that study is this diagram on the right side that shows you compared to patients without hypoparathyroidism, there's about a fourfold increase in kidney complications, including kidney stones and renal insufficiency. And so to decrease the urinary calcium, what we are currently doing is to lower the serum calcium, because on the right side, the normal serum calcium levels like 9.2, 9.5 are too high for hypopara patients, only because of the urinary calcium. Because then the urinary calcium is too high and there's a higher risk for developing kidney disease. So we are targeting low to low normal serum calcium levels, but then on the left side, they make you more prone to having symptoms. So that is the conundrum that we have heard today about, and that is something that the physicians have to deal together with the patients, and there's sometimes a good middle, but often there's not. And so this is my last slide, I tried to summarize or list some of the actions of PTH, and Certainly, I don't claim that these are all. And what calcium and calcitriol, the SOC standard of care, does, and the currently available PTH on the right side. So what we can do is increasing serum calcium. That's what we can do very well, but that's pretty much everything, right? So in the excess means it's not being fulfilled. So you see, everything else, standard of care really does not address. So normalizes urinary calcium. We just talked about this, right? It cannot do this. PTH 1 to 84, there are conflicting results. Different studies showed no effect. Other studies showed some. Keeping the serum calcium stable. We cannot do this with current treatments. There is the problem that how often do you measure calcium? Often it's once every so many months. Well, it tells you something about that moment. It doesn't tell you what was it in the morning, what was it later during the day, right? So I personally believe the fluctuations in serum calcium is a big lack of, we need to pay more attention to that, I think. Adapting to challenges, meaning what if a woman has periods and the serum calcium goes down? What if you're going for a run, right? These medications, you're taking the same medication. Only you can take extra ones. But really, in the best case scenario is someone else, like a parathyroid gland substitute would do that. Normalizing serum phosphate, actually, PTH does it very well. Current treatment doesn't do it. Normalizing magnesium, very similar. Bone turnover, so PTH products increase the bone turnover, and the goal is to increase it to a normal level. The ease of administration, that's a little bit in the eye of the beholder. Clearly, the current treatment, I don't think it's very easy to administer, even if it's just a tablet. PTH currently has to be administered as an injection. There are many people who say, well, this is not really what I want to do. Other people tell me it's actually much easier than taking all these tablets. Improving quality of life is a big issue. And protection against complications, so long-term complications. That's hard to know and hard to study because you will need a lot of patients over many years to really study that. So the summary is we need better treatments to address and replace the different functions of parathyroid hormone. I thank you very much for your attention.
All right, thank you so much, Dr. Mannstadt. Really appreciate all the work that you and Dr. Rubin do with the HypoPARA community. Truly, let's give it up for them again.